Can I just do a quick scope before I start? And can I have hands up? Who's a student? If you're a student nurse, can you just pop your hands up for me and keep them up just for a second so that I can... Thanks, Joe. Wonderful. Okay, just doing a bit of a scope there, because I do know that we may have some qualified nurses on the call as well, but it looks like the majority of you students. So welcome and thank you very much. Like I said, I'm sure a lot of you are you know, in your potentially second or third year, I'm very grateful because this is an incredibly busy time for you. I'm fully aware of that. So welcome to our webinar. My name is Amy Hilton. I'm the corporate lead nurse for NHS Blood and Transplant. I started in NHSBT about 2.5, nearly 3 years ago. And before that, I was a senior lecturer at a local university. And prior to that, I was an A&E nurse and school nurse and lots of different things. So I've had quite a varied career. But I came into NHSBT to introduce student nurses into our organisation. And you might think, well, hang on a minute, why did you not have them before? And we did trial it, but actually you'll see soon that actually as a national organisation, because we cover the whole country, it's really complex trying to make sure that students get a really good learning experience. So that's what was kind of my main aim when I came into the organisation a few years ago. We now have placements in with most of our teams across the country. So I'll give you a bit of a kind of idea of who we are and what we do. So we are a national organisation that deal with blood and organ transplantation and tissue transplantation, blood donation. And you're going to hear from each of our nurses that cover our specialities shortly. But we are, we have 1,000 nurses across the country, and they're all senior nurses that have specialised roles. So we have 4 directorates. We have plasma for medicine. You're going to hear from Claire later. We have organ donation, and that's kind of managed by our organ donation nurses and tissue donation nurses. We have our blood session nurses who manage and run blood sessions. You're going to hear from Cheryl, who's in my team, later about that. And we also have lots of little pockets like patient blood management, who you're going to hear from Sam first, who deals with all the transfusion practices in hospitals, making sure it's safe transfusion practice. And we know that is a significant part of your learning pre-registration.
Sorry.
Pre-registration. Sorry, that's really distracting. Pre-registration standards. So I decided to put this on purely because not everyone is always going to get the opportunity to come and have a placement with us, but it's to explain to you what we do, what our nurses do, and actually and if you did want to come to a placement, how to do that and how to kind of put your hand up and say, I'd quite like to go to NHSBT and work with the nurses. What we do when students come in, we rotate them around our services. So you'd spend time with the organ donation nurses, you spend time in a plasma centre if you were near one, you spend time with mobile blood teams and our therapeutic apheresis teams as well. And we've got our head of nursing from therapeutic apheresis that's going to come along and talk to you about exactly what they do. In their services. So I won't go on because I'm not the specialist. I just kind of sit here and welcome you all and get you all engaged. But they will talk about their role and exactly what they do in depth as we go through the morning. I really want you to take as much as you possibly can. So the nurses are going to talk about their roles and what they do, but also actually the specialism around it. So hopefully you're going to get some good insight into organ donation. You're going to get a good insight into what we use plasma for, and also safe transfusion practice, etc., and what therapeutic apheresis is. Because actually, before I came into this organisation, I had no idea. I had to Google it frantically, what therapeutic apheresis was, and we've got 100 nurses across the country doing that as a specialist role. So hopefully it will give you a really good insight, good idea about about what we do here. I really want this to be as engaging as possible. We have a form that Emma's going to put into the chat. If you have questions whilst maybe, you know, because Sam's going to start questions while Sam's starting, if you put it on the form, and then after that I will I'll ask the questions, I'll field the questions to Sam, but as interactive as possible. If you want to put your hands down now, as I've kind of got a good idea about who's a student nurse, I won't think that you're waiting to ask a question, but if you the questions are anonymized, so please don't worry, and I can ask them at the end. So I really hope you enjoy it. It is going to be recorded, so any friends that can't make it today know that we'll pop it up and they'll be able to access it. But I hope you do get something from it, and we will be asking for some feedback so we can make it better for everybody as we go through as well. All right, so that's me. I will now hand over. Stop sharing my screen. I'll hand over to Sam to introduce herself.
Morning, everybody. I'm hoping you can all see my slides. So my name's Sam. I'm a nurse. My background is predominantly renal medicine, but I specialised in anaemia management. And I'm going to talk to you today about patient blood management and the PBM England team. Someone's got a hand up, but I just want to make sure that you can see my slides okay, that there's not a problem.
Yes, the slides are up perfectly fine. Can I just ask if you would just before you start, Sam, just quickly, I am putting a link in the chat around Microsoft Forms, so any questions or any hands up, if you just fill the form in rather than pop your hand up, just so Sam's actually able to answer after a presentation. So the QR code will be going into the chat soon so that you're able to ask them questions via the Microsoft Forms, just so Sam can flow within a presentation. Thanks, Sam.
Perfect, thank you. So I'm going to talk to you about patient blood management and the PBM England team. Don't panic if you have never heard the term patient blood management, because I was actively delivering this in practice for probably about 10 years, and I'd never come across this term until I stumbled on the job advert. But by the end of my presentation, hopefully you'll know a bit more about patient blood management. You'll nod and you'll recognise bits of this in practice that you've seen, and hopefully you'll know a lot more about the PBM England team. So this is us. So we're called the Patient Blood Management England team because we only cover England. The devolved nations and blood services, so Scotland, Wales, Northern Ireland, they have their own teams, they have their own processes. So we're scattered across the 7 NHS regions. We have 2 practitioners that work with us that kind of cover everything and support all areas of work and activity. And like everyone, we have a management team. So we have our lovely ops manager, a development lead and an education lead. And that feeds into our national PBM lead. And we sit within a kind of very small directorate that's the transfusion directorate within NHSBT. So a really good place to start is, what is patient blood management? What do we mean when we say this? Well, it's an international initiative. It's not just something we've concocted in the UK. The World Health Organization have endorsed this since the 90s, but in 2020 they published a policy brief, an updated policy brief, which was really a strong call to arms for global healthcare providers to start adopting patient blood management as a standard method of care, just like aseptic technique is a standard method of care. This is what our go-to approach should be. And it's a multidisciplinary, evidence-based approach to optimizing our patients' own blood volume, so minimizing blood loss, managing anemia. So the next presentation you have is from our blood donor colleagues, and they're going to talk to you all about the amazing work that goes on in donation. So think of my team as the everything but blood team. And it boils down to 2 clinical questions. Is our patient actively bleeding or at risk of bleeding? Or is there another reason why they might need a blood transfusion or be at risk of needing a blood transfusion? If the answer is yes, then the next question we should ask is, can we use any other treatments? Are any other treatment methods appropriate? And what can we do to manage, mitigate, or avoid that risk? And the reason I talk about risk of transfusion is we're really lucky in the UK. We have a relatively safe blood supply. In the grand scheme of things that we do to our patients, in the grand scheme of blood supplies across the globe, we do everything we can to make transfusion as safe as possible, and it is relatively safe, but it's not totally risk-free. There are incidents, there are issues, there are risks associated. So if we can avoid those because a patient can have another alternative treatment, then that's great. So it's based on 4 principles. Now, this has kind of evolved over time as we understand more about patient blood management, as we get more evidence. It used to be based on what was called the 3 pillars. It's evolved to 4 principles, but initially the first 3 remain the same. So it's about, the first pillar is about, this principle is about promoting our body's own ability to make its own blood cells. So removing any barriers to that process of making blood cells, making sure that our body's got everything it needs to make its own blood cells. The second principle really is around minimizing blood loss. So it's quite surgically focused, this pillar, but it applies to obstetrics and labor. It can apply to major hemorrhage and trauma. And it's really looking at things like managing risk of bleeding. It's looking at surgical techniques. So it can be something as simple as diathermy and cauterizing those tiny little vessels. That reduces quite a significant amount of blood loss. But it can be as specific as something like cell salvage, so catching and returning patients' blood. It involves drug treatments that help reduce blood loss, and there's a lot of point of care testing now, these bedside tests that give us rapid results that can guide what we do, what we give, how we give it. The third pillar, I kind of don't really like this update. It talks about optimizing coagulation. Now, coagulation is really important. We want our body to clot so that it heals, so that we keep our blood in our vessels. But the original third pillar went a bit beyond this, and it talked about optimizing our patient's ability to tolerate a drop, particularly in hemoglobin, really, but thinking about that good quality nursing care, avoiding infection, whether that's a post-op wound infection, whether that's a hospital-acquired pneumonia, or treating it if it happens and treating it quickly so that it doesn't add to the symptom burden. Thinking about treating symptoms, if we've got patients that are short of breath, let's give them some oxygen, let's get them moving, let's get some, respiratory, physio in, or whatever we need to do. But it's also about hydration, good quality nutrition, getting our patients moving, because if we do all of those things, if they have had a bit of a drop in their hemoglobin levels, they're going to tolerate it a lot better, and we might then not need to think about other treatments or transfusion. And then the final principle, the newest principle, is a real focus on patient-centered decision-making. So I'm pretty sure you've all stood at the end of the bed on a ward round by now and heard a conversation go along the lines of, oh, we've noticed that your red blood cells or hemoglobin levels have dropped a little bit, and we'd like to give you a top-up. Are you happy to have a transfusion? Now, on the surface, there's nothing wrong with that conversation as an opening gambit, but quite often that's where it stops. And we don't offer our patients any other alternative. We sell it as that's the only treatment option. But if that was a patient who we knew because they'd got an advance directive, or it was a well documented that they didn't want to have blood, they wouldn't accept blood, or if they said, no, actually, I'm not happy, that conversation would look really, really different. And we'd give them all of this choice, and we'd give them all of these other options. And in reality, we should do that for every patient, whether we think they'll refuse a transfusion or not, because how else do we empower truly informed consent if patients don't know their options? So that's our 4 principles. So what do we do as a team? What is our role as a patient blood management team? Well, we support any patient's journey, healthcare journey, promoting the application of those principles and the use of alternatives to transfusion. We're a team made up of specialist nurses and scientists and midwives as a practitioner team, but we also work with some fantastic haematologists, and we have an amazing group of administrators that support everything we do and keep it going. We predominantly work with healthcare providers, so we kind of work at a hospital trust level, but we can work with clinical teams, we can work with individuals, and I'll go through some of our kind of key collaborators, but it's all about implementing and embedding that approach to patient care. Now, the PBM England team, we kind of take what we do in our work a step further than the internationally recognised definition of PBM. We ask a third question. So if you've looked at all the other alternatives, all the other options, and you've decided they're not appropriate, or if your patient's decided that actually they don't want the alternatives, they want a transfusion, or if your patient is actively bleeding and transfusion has to be the first line treatment, we ask another question. How do we do that safely and appropriately? And so a big part of the work we do is, as Amy mentioned, is we look at safe and appropriate transfusion practice. We support the National Comparative Audit of Blood Transfusion Programme. So this is a little team that sit within NHSBT that carry out a lot of our comparative audits. And it's not just around blood transfusion, it really is around patient blood management and how we approach transfusion practice and how we optimise our patients. We really promote PBM in every avenue by every method we can possibly imagine or think of or find. And I'll talk a little bit more about that as we go along. So our team has undergone a bit of an evolutionary process as well. So back in the 90s, we were actually called the Hospital Transfusion Liaison Team. And our work was really centred on the back of a health service circular called Better Blood Transfusion, and its sole focus was appropriate use of blood. Fast forward to 2014, and the National Blood Transfusion Committee set out a framework for patient blood management. And therefore, our team evolved from being solely around appropriate blood to embracing this PBM approach, and we transitioned to patient blood management practitioner team. So what guides our practice? So we had the framework that I mentioned. A year after the framework was published, NICE produced a set of blood transfusion guidelines. And again, we call it blood transfusion guidelines, but these guidelines are so much more than that. And they do talk about this PBM approach. Can we use alternatives? Can we avoid that risk? Can we mitigate that need? And if not, how do we do it safely and appropriately? On the back of the guidelines, another year later, NICE published a set of quality standards. So these are 4 kind of key benchmarks that hospitals should be aiming for to ensure that we're giving the best quality care that we can. And these quality standards are the first being that if you have got somebody going for surgery, that they are investigated for any anemias, and if it's iron deficient anemia, that they are offered supplementation prior to the procedure. So we're optimizing them. We get pillar 1, principle 1. We're thinking about making sure our body's got everything it needs to make its own cells, red cells. Quality standard 2 is, again, looking at adults having surgery. If it's a surgery where we anticipate there could be moderate blood loss, which is usually termed around 500 mils, they're offered a drug called tranexamic acid. So this is your pillar 2, or principle 2, thinking about minimizing blood loss. And if you don't know, tranexamic acid is an antifibrinolytic. That's a bit of a mouthful, but it's basically a drug that stops our body trying to break down clots. Now, if we're bleeding and it's a lot of blood and it's high pressure, there's a lot going on. And what we want to do is stabilize clot formation, because if we clot, we keep our blood in our own vessels where we want it to be. And it's a cheap and cheerful drug. It's readily available, and the evidence base behind it is vast. It's very, very effective with very, very minimal risks and side effects. Quality standard 3 talks about clinically reassessing patients after each unit of blood, unless they're actively bleeding or they're somebody that we know needs chronic transfusion. So thinking about our hematology patients, our myelodysplasia patients, where we know they need that blood and we know they probably need a good few units every so often to keep them topped up. How many times outside of those environments, though, have you seen 2 units just hung one after the other? But how do you know? How do you know that patient needs that second unit? Everybody's needs are different. It's why we should never look at numbers and values alone. We should always look at the patient and carry out holistic assessment. Because I've had a patient, big burly chap, walk around with a hemoglobin of 70 and absolutely fine. But then I had anemia when I was pregnant and my hemoglobin was only 90 and I felt terrible. It's not one size fits all. So we should be checking our patients' symptom burdens, and we should be checking their hemoglobin to guide and make sure that we know they really do need that other unit. Quality standard 4 suggests that people who may need a blood transfusion or who have had one, maybe in an emergency situation where we couldn't go through all the ins and outs at the time, they're given verbal information, and it's a good quality conversation, thinking about the pros, the cons, the risks, the alternatives, and then they're given written information about blood transfusion, because we know that it's very difficult at times for patients to retain all of the information that we give them, but we know to get informed consent that they need to be able to retain, recall, and weigh up all of the information that we give them, and written information really supports that process. So NBTC, as well as laying out the framework in 2014 of what patient blood management looked like, they sent a set of recommendations for hospitals on how to embed this. So really focusing on educating clinicians, on championing and PBM, having a real structure to PBM management throughout the hospital, and getting that buy-in from senior management, from exec, so that multidisciplinary approach. Fast forward to, it should have been 2019, but it was actually published in 2020, so a little bit behind schedule, was Transfusion 2024. So this was a joint brief delivered by the National Blood Transfusion Committee and by NHSBT, delivering a 5-year plan for clinical and laboratory transfusion practice. And although we talk about transfusion, we're really talking about PBM, and PBM practice is a really strong factor in this 5-year plan. So it's really looking at how we digitalize and use digital technology in transfusion practice. It's looking at what resources we need, what education we need, what staff levels we need. And it's really all about that safe and appropriate approach. So how do we do it? So I said we've got a big old list of collaborators and working groups. So some of them I've already mentioned, but it's really vast and it's really broad, and it can be anyone from NICE to NHS England. We also do some work with Health Education England. Lots of internal collaborators as well, our blood stocks management scheme, our customer service managers who also support hospital teams, our blood and organ donor teams, right down to hospital level. We can work with individual clinicians, individual teams. We work with Royal Societies, so it's vast. Any opportunity where we can support people to embed, utilise PBM, we're there. So we've talked a little bit about the National Blood Transfusion Committee already, and it's fine if you've never heard of them either. But they sit at the top of a sort of hierarchy. And it starts at the bottom, really, with hospital transfusion committees. So these are the committees within a hospital trust that are responsible for transfusion practice in that trust. And it usually consists of a haematologist responsible for the blood bank, your transfusion lab managers, your transfusion practitioners, and there's a chair for the group, and there'll be key stakeholders as well. So usually areas where they use a lot of blood or where PBM is really, really required. So again, obstetrics, theatres, ED, really key areas. They tend to come along to those committees as well. Excuse me. And then that feeds up to a regional committee. And this is all about those key personnel from your hospital, sharing best practice, raising any issues or incidents, collaborating to overcome challenges, benchmarking, educating, supporting. It's a really, really great network. And then that feeds up to the National Blood Transfusion Committee. At a practitioner level, I really support and facilitate the regions and the hospitals, and our SMT kind of get involved at a national level. As I said, we employ every opportunity to get the message out there and to support practitioners and clinicians and everybody to embrace PBM and to utilise PBM in practice. And we do everything from education, so e-learning modules, through to toolkits. We've got a YouTube channel with amazing presentations on just about every topic you can imagine related to transfusion or patient blood management. The toolkits are literally go-to guides on how to embed this and how to approach this. So we might have sample business cases in there. We might have sample policies or processes in there. We may have audit material to help you audit your services. We'll have the evidence and the guidelines in there for you to understand why this is important. So the toolkits are a one-stop shop. Patient information leaflets. So if you've ever handed out a patient information leaflet about blood or transfusion, the likelihood is it came from our team, and we developed that and delivered that. We've also just built in the last 5 years 2 clinical apps, and they're available from any app store for free. The one, Blood Assist, is probably really, really useful for you in practice because it is, again, a one-stop shop for that bedside transfusion process, covering everything from consent to specific requirements, to adverse reactions, what to look for, how to monitor it, to that bedside checklist and safely transfusing and checking your blood components. It's all there in an app. And then there's another app called Blood Components. Now, this really focuses, as I said, on that evidence base about what to transfuse, how much to transfuse, when to transfuse. And it covers red cells, platelets, plasma, and it brings all of the evidence about, what we do and how we do it in terms of when to authorise blood and when to give blood, rather than sort of, a finger in the air, 2 units will do the job. I talked a lot about audits and surveys already. So we do a lot with our regional committees and hospital committees supporting their local audits and surveys. But we've recently just developed a quality standards improvement tool, really. It's a consistent or a continuous audit tool, measuring against those 4 quality standards, so hospitals can see how well they're doing, how consistent they are, and they get to benchmark themselves against other hospitals in the region, nationally, and it really gives them that picture of where they need to focus and what they need to work on. And that's just been endorsed by NICE. We do a lot around emergency transfusion and emergency planning. So again, this is really thinking about that safe and appropriate transfusion. And when you have an emergency situation, there's usually a big need for blood and there's lots of room for things to get complicated. So we really focus on making sure that it's safe. I'm sure my donation colleagues will be talking a lot about how precious our OD negative resources are, and that's our universal donor. So in an emergency, anyone can have OD neg blood, but it's a very, very scarce blood group. I think it's either between 4 and 7% of the population at OD neg, so it's not a lot, and only a percentage of those will be donors. So we really need to protect our emergency blood stock. So a very quick whistle top, I'm not sure where I am on time, of what this looks like in practice. So we're very quickly going to follow a 77-year-old lady having a total hip replacement. So she's going to be referred by primary care. She's going to see pre-op to make sure she's fit and well for surgery. She's going to be admitted, have the surgery, have some post-op care in the ward and be discharged home. So this is the multidisciplinary team that we want involved in delivering patient blood management. And it starts in primary care at the point where they're making sure that patient's fit for surgery, that they are, making an appropriate referral. They're going to highlight things like medications. And thinking about PBM, we want to be thinking about antiplatelets, anticoagulants. We want a past medical history. Again, thinking about any conditions that might make them more clot because we need to manage that, or more likely to bleed because we need to think about that. At this point, we would love, in our ideal utopia world, we would love our primary physicians to be thinking about anemia, because the likelihood is they will have taken some bloods already. So if they note that they're anemic, let's start that process of investigation, because we know from the evidence that earlier we do this, the better the therapy, the better the outcomes. But in practice, at the minute, that's happening at the pre-op assessment stage. This is where they're identifying the anemias. This is where they're investigating, and this is where they're starting the treatment. And if we can bring that forward, the outcomes are much, much better, and it's much more effective. But at this point, they're really going to pick apart that assessment and that bleeding history and that medication. And this is where you start to make those plans about if you've got a patient on warfarin, when they stop, when they restart, do you need to bridge their anticoagulation? So all of those plans around bleeding risks, they'll take the blood samples. If it's a moderate blood loss procedure where we think they might lose a bit of blood, they might be at risk of transfusion, we're probably going to take a group and screen so that we're not reliant on that emergency blood, that we know roughly what blood group they've got. We're going to consent our patients. We're going to talk about the risk of needing blood, and we're going to consent them. So we're going to have that good quality conversation. We're going to talk about the alternatives, and we're going to give patients that written information to support their decision-making process. In the theatre now, ladies having her surgery, we're thinking about minimising blood loss. So we're going to use some TXA. It's very, very much indicated in NOF repair and hip replacement surgery. We're going to think about cell salvage. Again, that point of care testing, making sure that we know what's going on in a real timely fashion, and that guides our treatments. And we're thinking about safe and appropriate blood transfusion if we really need to do it. And then post-operatively, jumped ahead. There's no reason we can't think about, all of those things in terms of optimizing our patients. So are they still iron deficient? Do they need iron? Because we shouldn't treat iron deficiency with blood. It's not going to solve the problem. It might, scratch the surface and make the hemoglobin look better. But if they haven't got the iron, it's not going to help. And then it's thinking about if we do need to transfuse, doing it appropriately. So don't give 2 without review. Make sure you check before you give a second unit unless a patient's actively bleeding. Why? Why do we do this? Patient benefit. The patient benefit is huge. It's so varied. The evidence is really, really strong on so many different levels of patient benefit, from reducing length of stay in hospital to enhanced recovery to improved morbidity and mortality outcomes, reducing post-op complications. It's really, really broad, and there's so much benefit. I've already banged on about patient choice, but we cannot truly be gaining informed consent if patients don't understand their choices and their options. Sustainability. Blood is not something that we yet know how to manufacture and make. It's donated, and every donation is really, really valuable, and we should be making sure that we utilise every unit in the most effective, appropriate way to make sure that blood is always there when we really, really need it, when there is no other alternative. And cost. We don't like talking about cost in the NHS because it makes us feel like we're being a bit cheap, but we all love an Aldi bargain. Why pay more if you don't need to? Blood is not a cheap process, not just in terms of the component, but in terms of your time, your resource, that bed space, the lab's time, their resources of processing and testing and sampling. So it's not cheap. And when you compare that to the alternatives and the other therapies and that risk management approach of reducing blood loss or avoiding blood loss, it's much more cost effective for patient care. What I love about my job, so it's patient focused. Everything we do is about the patient. I might not always be at the bedside, but everything I do is for the patient and is setting that gold standard of care for the patient. In some very, very small, remote way, we also get to support the care of our donors by making sure that valuable unit and donation is used in the most efficient, effective way. We can reduce the demand on our donors and the pressure on our donor population. A variety of work streams. I get to do so many different things. No 2 days look the same in PBM, and then the opportunities to do various things. So I sit on the British Society of Haematology Working Group at the moment, supporting the rewrite and update of the perioperative anemia management guideline. Never thought I'd do that. I've delivered educational content for an international PBM forum. I've presented at conferences. I get to teach nursing students. It's fast and it's amazing, and there's so much autonomy in what we do. I know my region, I know my hospitals, I know my teams. So if there's something I need to take forward in action, I am given that choice on how I deliver it and how I work with all of those stakeholders to the best effect. And I get to play to my strengths. I'm an anemia specialist, so I do a lot of work around anemia, but I also get the choice to build on the skills that I don't know so well and get involved in the areas of PBM where I haven't maybe been as clinically aware. And the people, that's by far the very, very best part of my job. The team, the PBM team are amazing. But actually everybody I work with in NHSBT, every time I reach out to somebody, every time I need a bit of help, everybody is so knowledgeable, so supportive. But even within the regions, and I have to say, this is where the NHS shows what it's capable of and how amazing it really is I sit around the table with all of the TPs in the region or all of the TLNs in the region, and I watch them support each other and I watch them help each other, and I watch and see the dedication and the passion and the knowledge, and it's amazing, and it reminds you why we do what we do and just how good the NHS is, really. So that is a very, very whistle-stop tour to patient blood management and the PBM England team.
Thank you so much, Sam. I want to come and work in PBM. Just say, you're a great salesperson. It's fantastic, and thank you so much. I think even for the nurses sat around the table within NHSBT, we've all learned something today. So really appreciate that. I'm just looking through the questions at the moment, and we haven't got any specific for you. And I will any questions about placement, spoke days, etc. I can answer at the end of this webinar. But there's nothing specific for you. But if there is, I will give you a shout, Sam.
So if you want any of the resources, any of the information, if you type hospitals and science into Google, it will bring up the hospitals and science webpage. Where the third drop-down box along, you'll find patient blood management. All of the resources are there, all of the information's there, and our contact details are there. So if you do think of a question, if you do want to come and spend a day with somebody, reach out. We're here. We're very friendly, and we'd love to have you along.
Thanks, Sam. I definitely recommend it as well, because like I said, it's part of the proficiency, but it's something that wherever you work at any point in your career, you will come across transfusion, or you'll come across the need for supporting people with transfusions wherever it is. So, or, you know, managing people with low hemoglobin, etc. So I think it's vital just to have that understand of the process, and hopefully everybody will develop a bit of an idea about where blood comes from and that whole process. So thank you so much. And I would absolutely recommend, and whenever I go back and do teaching, I always say to students, please download the Blood Assist app. It is so helpful. When I deliver teaching on blood within simulation, I'll always use it and say, this is absolutely vital when you're bedside. And we all know that, you know, those kind of apps and support out there is vital for those for when you're kind of rushed and pushed and trying to make clinical decisions. It's really, really helpful and supportive. So do download the Blood Assist app. Sam, if you wouldn't mind putting the link into the chat box, if there is one, that would be fantastic, so that people can have a look at that. Wonderful. Like I said, there's no questions about anything that Sam's said at the moment. So, but do keep them coming, and Sam will be around, and I can always tap into her if there is something. So I will now hand over to wonderful Cheryl, who is working in my team. She's actually the National Resuscitation Lead in the corporate nurse team, but she was a blood session sister for a very long time. So she's going to talk to you about what we do on blood donation sessions. Cheryl.
Thank you. So thank you everyone for coming along again. Just to echo, it's so nice to see so many of you joining today to hear about NHS Blood and Transplant. For me, it's been absolutely career changing to come to an organisation where we are able to help people a lot of the time indirectly every day. So yeah, I'll go over the blood donation side of things. Like Amy said, I currently work within the corporate team, but I did previously do quite a few years on a mobile blood collection team up in the northeast. So blood collection is either in donor centres or out in mobile teams. And like I say, mine experience comes from the mobile side of things. So from today, we're going to go over who can donate, because not everybody is able or eligible to donate their blood. Donor consent, the process of the blood donation collection, the products that can be made, the journey of the blood products, and what nurses do, what their role is in navigating that collection process. So a few little facts and figures there just about blood collection. So like I was saying there, we're either donor centres or mobile teams. There is more mobile teams, and basically what a mobile team is, it's a wagon and a minibus. We pack all our staff into the minibus, we pack all our equipment into the wagon, we drive out to local areas, community centres, hotel, function rooms, that type of thing, church halls, any space that we can find to set up our pop-up sessions, and we're there for the day. And generally mobile teams will collect roughly around about 100 to 120 donations per day. So it's a lot. It's a very busy session, and it's really lovely that we're out in the community and people can come along local to them and save a life. Basically, with an hour of their day saves a life. Every year we need approximately 135,000 new donors, just to ensure that we keep ticking over. Just like Sam was saying, blood is so valuable, and it's really a resource that can't be wasted. It's just such a life-changing product for the people that need it, people with chronic conditions, even palliative care treatments, and that it only is able to be delivered to those patients because of the goodness of the population who take their time out of their day to come along and donate their blood. So blood and platelets, as echoing really what Sam was saying, they're used a lot of the time in emergency treatment for trauma patients, or surgery if there's obviously a planned surgery with a potential high risk of bleeding, and the O negative blood is like gold. So the universal blood group's O negative, so anybody basically can receive that. And differently for platelets, anybody can receive A negative. So when we are looking for platelet donors, it's a little bit different. We look for A negative being the universal blood platelets that we can give to anybody, and to be a platelet donor, there's a few more few more things that you have to meet the criteria to do solely platelet donation rather than just blood. So if we go on to who can donate. So like I said, not everybody's eligible, and that is for two reasons. One, we need to keep our donors safe. Their safety and their health is paramount. So we don't want to put anyone at risk by them giving us their blood, basically. And also we need to think about the safety of the recipient. So the people that are going to receive this blood a lot of the time are not well themselves. They're in poor health, they have chronic conditions. The last thing they need is to be given some blood that's going to make them sick. So people can donate from the ages of 17 all the way up to 66 for new donors, or if you have donated, you continue to donate, you can donate as long as you're fit and well. There's no age restriction that we stop taking regular donors. And for me, as the population, we are an ageing population, very fit and well. Some of our elderly donors were coming in their 80s even and giving donations absolutely fine, and it's just so lovely to see. And a lot of donors, they get to their 100th donation, and we have a little celebration out on session. And they receive awards. It's a donor recognition program. We do dinners for them so they can attend events, and it's lovely. So our donors, like I say, we wouldn't have any of these products if it wasn't for them. So we do recognise the donors and their kindness at milestones. So people who are fit and healthy, basically, how do we define what fit and healthy is? So blood donation nurses, we have the responsibility to do the enhanced health screening So if somebody comes in to donate, they fill in their safety checklist, basically the health checklist. Our donor carers, who are our support staff, healthcare assistants is probably a better term and more widely used term, but within blood they're called donor carers. They will do the first leg of the health screening, and if there is anything that is untoward or needs a nurse's review, then the nurse will do, like I say, the enhanced health screening. And we use some guidelines that are all online. It's an open website. The abbreviation is JPAC. I will put the link in the chat because it's really interesting website as well. Like I say, it's just open to the anybody can go on it. JPAC is an abbreviation of a very long name for the committee. It's basically just the transfusion guidelines for the UK, and there is bits and pieces on there that you will probably find quite interesting. Not relating to blood specifically, but travel, all sorts, and general health conditions. So we can go through there. We can look on the transfusion guidelines, and we can see if somebody has a medical condition, for instance, that would prevent them from donating. And that might be that they can never donate, or that might be that they need to maybe be deferred for a specific amount of time, which means they can come back in the future potentially. We need donors to be of a certain weight. I mean, it's not a tight weight restriction. It's basically for making sure the blood volume for the lower weight, that you have enough blood to give some away. We're not going to be stealing too much and making you unwell. And then also just the maximum restriction is just with regards to safety for the chairs and what we can manual handling basically. Men are able to donate every 12 weeks if they are fit and well, so they can come along every 12 weeks and donate their blood. Women is 16 weeks. And the reason for this is that men replace everything we take from them just slightly quicker than women do. So they've replaced everything that we've taken off them just that little bit sooner. And that's the reason for the difference. Every donor, before donating, they go through their health screening. They then have an HB check just to make sure that their haemoglobin is adequate for us to take, and that we're not going to make them unwell by taking blood off them. So women have to have a haemoglobin of 125 or above to be able to donate, and men have to have a haemoglobin of 135 or above to donate. And like I say, that's just so when we are taken, we're not going to push them down into being anemic or near anemic. We do also look after and do blood donations for patients who have hemochromatosis. So this is a condition where donors produce in their blood, they make too much hemoglobin. So their hemoglobins can be anywhere into the really high hundreds. And NHSBT liaise basically with their haematologists, and we are able to see those patients up to every 6 weeks, so they can donate a lot more frequently if for their health it is beneficial. The treatment that donor and patients, with hemochromatosis sometimes do is they go into hospital and they have a procedure called a venesection. So they would go into hospital and they would basically do the same thing. They would have some blood taken out of their vein, and it is discarded in the hospital setting. But we can utilise that within the blood donation process, and we can keep that blood and obviously use it and put it to good use rather than it being discarded in a hospital setting. So it works both ways. It's really beneficial to the patient that has hemochromatosis, because we're keeping their levels where they need to be, and we're stopping them from being symptomatic with their illness. And we're also getting blood from that too, a blood donation from that. So again, that's really, really beneficial for both parts. And our clinical support team, which is doctors and specialist nurses, they liaise with the haematologists from the hospitals, to ensure that we're safely allowing these donors to come along and provide a blood donation rather than having the venous section being discarded. So the consent process, oh, if we just go back. Sorry, consent process. So every donor, when they come in, they must sit and they must read through our consent booklet. And this is basically just to advise donors that they need for them to be completely honest with us. So you can see there, you must never give blood if, and then it lists, and it's just, we rely on donors' honesty within their forms, within the health information that they share. We don't have any access to hospital records, GP records, anything like that. There's no kind of magic electronic system where we can see everything that they've had done in their previous NHS treatments in other NHS establishments. We rely solely on donors being honest with us. So that the reasons for that and the rationales are in this consent booklet. It also goes over things regarding adverse events. So no medical health procedure is completely safe, although it is relatively safe. You're very unlikely to have any sort of adverse event from coming and giving blood, but it does happen and it can happen. So that is all explained in that consent booklet as well. The donors then sign their health declaration to say that they are being basically 100% honest and they understand the repercussions or what could happen should there be anything not declared, basically. Alongside consent, we do participate sometimes, occasionally, with studies and trials within NHS Blood and Transplant. We've just finished a really big study with Cambridge University. The nurse's role on session with that was to recruit people to be a part of the trial, and alongside that meant obtaining additional consent. So we had to go through the consent process, informed consent, being sure that the donor was fully aware, fully understanding and recognising the ethical sides of gaining that person's consent. So again, it's just making sure that you are happy, that the person within your care knows what they're signing up to, basically. So the donation process, we have basically a little conveyor belt in a room, and your donor goes on their journey throughout that little clinic setting. So they come in, they're welcomed. We provide the donors then with their consent book. They have a drink, they sit down, they have 15 minutes to have a drink of water, try and get that blood pressure optimal for donating blood. And then once they've finished they're reading the consent booklet, they're taken into health screening. Like I say, this will be initially provided by a donor carer who will go through their health questionnaire with them. And then if there is any additional screening needs, the nurse can go in. They have their haemoglobin test at this point also. And again, with screening, I keep saying health screening, it's also about travel and being outside of the UK. So we screen for people that have been to countries that may have viruses or known outbreaks of different things. It's all on JPAC again. You can search each country. And yeah, so it would be potentially that we may have to defer someone, say if they've been to an area that's endemic of malaria, for example, until we can be sure that that we are able to test for that in their blood. Once they've passed screening, they're able and eligible and safe to donate. We take them through with the donation area. And for those of you that maybe haven't donated blood or haven't seen the donation process, it's basically you sit on a reclining chair, your venipuncture. It's very the donor carers are fabulous, brilliant venipuncturists, and basically you get one shot. We can have one try, one try on a vein, and if they don't get it, then unfortunately you're not able to donate that day. And the theory behind that is you're coming along as a fit and well person, and we don't want you leaving in any other way. So for us to be continuously trying to get needles in your arm and things like that, it runs a risk of causing damage to your vein. We want you to be able to come back next time and try again. We don't want you to end up with a nerve injury or anything like that in that arm. So providing you have suitable veins, the donor carers will attempt one venipuncture, and touch wood, a lot of the time that's all that they need, because like I say, they're brilliant and this is what they do day in, day out. So your donation, you have your venipuncture, you sit there for up to 15 minutes. Generally, it doesn't take 15 minutes to get that donation. I would say on average, it's about 6 or 7 minutes, and then that donation pack's full. We take that down. We give you a couple of minutes in the chair just to make sure that you're feeling okay, basically, and that site has clotted and stopped bleeding. At this point, some people do feel lightheaded, dizzy, they can have a vasovagal and lose consciousness. We do try and treat all this on the donation chair. The donation chairs are able to tip right back, so we would have your legs elevated above your head level and you would be lying flat. At times, there is donors that can take quite a few hours to feel well. Like I say, this is very, very few and far between, but it can happen. So your nursing care does come in to this side of patient assessment, basically making sure your donor, you're happy for them to leave that session and safely get themselves home, basically. There is times that if that's not the case, we've had to ring ambulance as for people, they have had to attend E&E, and like I say, that is really few and far between, but it does happen. So that would be your next stepping point for health assistance for donor concerns that you had. If none of that happens, all being well, your donor's donated, they're fine. They head over to the refreshment area and they sit with a member of staff for a little 10-15 minutes, have a drink of juice, have some biscuits, have some crisps, and then off they go. And like I say, most of the time, that is how the process happens. And with the blood product, we take it from the donor. It's all labelled up with the donor, the barcodes on the blood bags that you will see in practice. We stick them on them blood bags in session, and then they don't get removed, so they follow the process. They follow that blood product all the way through. And those labels, they all correspond to the blood product, the blood tubes, the donor DSC, which is the donor safety checklist, all have the same corresponding barcodes on, so that we can have an audit trail for anything that may go untoward in that process from being collected to being given. So we are able to follow up on that. And if we move on to the donor recovery at the bottom there, so the nurse's role in blood donation. So when I seen the job for a nurse in blood donation, I thought, oh, that's a nice job. I'll just go and pop the needles in and get to chat to people. And as much as I then realised it was not just doing that and putting needles in. The nurses don't actually do the venipuncture. It's the donor carers that do this venipuncture. And as a nurse, as a registered nurse on session, you are there to be solely responsible for the safety of everybody in that room, basically. That whether that's donors, staff, anybody accompanying donors into the donation area, the safety of the equipment, the products, everything, basically. You've got to have eyes on everything. You also have to oversee the clinical assessments of the donors to ensure that the products are safe. You need to have be assured that your staff are reconciling the product safely, the products are packed away safely, and you're kind of a little bit of everything while you're out on session. So you're looking for your donor safety, whether that's the adverse events. Also the clinical assessments of donors, and it can be a lot, and a lot of the time you will be the only nurse out on session, but again, it's a real achievement once you get to the end of the session. You see all those blood products that you've collected within your team, and it's a real sense of achievement at the end of the day. And again, just providing a really nice atmosphere for these voluntary donors that are coming in, spending their time doing this good deed, saving a life, and we want it to be a nice experience for them, and then also for our staff as well to enjoy their working day. So it is a lot to it. It's very, very varied, but it's a lovely type of variation. Right, so if we move on to what students can expect to learn, excuse me, like I say, it is so varied, and especially nurses out on the mobile teams. I have shoveled snow to get the wagon into the car park with just all sorts. The possibilities are endless. I've had to ring gas engineers, all sorts. So you learn how to, what's the word? How to adapt and how to problem solve within these situations. And it's a lot of the time, it's not things you're kind of taught at university what to do with, or you can experience on a ward, but within the organisational demands, you know you need those products, and I know why I need those products for those patients. So it's using all those management and leadership skills, utilising those to get the end result that we need. So student nurses, you can learn improvisation skills, you can learn people management skills. We do, like I say, have a team of donor carers that are out, generally 10 donor carers and 1 nurse. And as the nurse, you would be their kind of line manager in that situation. So people management is a big part of your day. Informed consent, like I said earlier on, you can learn about the consent process, and that can be valuable to take across a variety of nursing roles. Quality and audit processes, it's very, very heavily audit focused, and we do stick to guidelines rigidly. There's no kind of grey, it's black and white, and that's really, really evident to see when you're out on practice, out on session. So your clinical decision making, along with your guidelines, working through history taking, you get a really good knowledge of just the general population's health. You'll see the same conditions over and over, and then you'll get one random one that you haven't heard of before, and you learn something new every day. So people come in with different conditions that you then have to look into. You have to work out if that's going to impact blood safety, if that's going to impact their safety. So there is a lot to learn from health screening as well. But again, with regards to screening, sometimes people aren't eligible to donate, and it's having those difficult conversations because some people aren't happy that they're not eligible to donate. So it's using communication skills and developing communication skills to enable you to have those conversations as well. So if we move on. So the products, as Sam said earlier on, when we take a blood donation, we fill that bag there with 470 mils of whole blood. There is 4 bags in a pack, and those other bags are used during the manufacturing process. So they go in a big machine called a centrifuge, and basically that splits the products, the blood, into the different products. So you'll have your red cells, your plasma, and your platelets. So one donation can help 3 people. They make platelets and plasma also for donation from them whole blood donations if needed for the blood group, and that can be pooled with with other products from the same blood group to make a full donation. So yeah, that's the products that come from the whole blood donations. So once we've collected the products, they go to main sites throughout the UK. Up north, ours is Manchester, so all the blood collected from up north each day goes down to Manchester for processing. And there is a site in Bristol and there is a site in London also that blood goes to. So each product has rigorous testing. So we do sample tubes at the bedside as well, like I say, and they have the same barcodes on as the blood product. So those sample tubes will be tested every time the donor donates for a wide range of things. So bloodborne viruses, all sorts. We can do additional screening. We can put additional tubes in for malaria as well if needed. And we can also take tubes at the bedside for potential platelet donors. If they want to donate platelets in the future, we can take the samples there to see if their platelet count is high enough. So they all get sent through with the products to manufacturing. They then go to our hospital services who store the products. And then from there, the hospitals put in, for want of a better word, a shopping list for what products they need, and each hospital is then provided with the products from our hospital services department. We have centres throughout the UK as well that stock emergency blood, so you might, or rare blood sometimes if it's for a specific patient, or you might say like the emergency blood bikes, for instance, they can pick up a specific unit and take that to where it may need to be. And that happens nationally. So I'll just let you have a little read through this. And again, the people that receive our products are at the heart of what we do. And for people living with chronic conditions, basically the good deed that the general public do, going to donate, keep them alive or enhance their life to a standard that they are able to kind of function for a lot of people. And like I say, it takes an hour out of your day to go along and donate blood. And us as nurses, NHS staff, we need to obviously value these donors. They're taking the time out of their own day to come along, and they're saving lives, and we need to respect and really care for them to the highest standard that we can, because they're just priceless, really. As Sam said earlier on, there's no artificial way to make blood. We need to get it off our donors, and they're putting themselves at risk every time they come in, and it's out of their own goodwill. So yeah, it's you never lose sight of that, and you do always value the people that come in, and you've got the stories like this at the foresight, and that's why we're doing it. So any questions? I would be happy to answer if there's any questions anyone would like to ask.
There is questions, Cheryl, as it goes. Thank you very much for that. So I've got one here, and it might just take a minute for you to digest the question, but it's certainly something about donating. So there was a student nurse who was volunteering in West Africa when she was 21, that was 10 years ago, and contracted cerebral malaria. She have tried a number of times to donate, but are not allowed, although she's O negative. However, I've no malaria or bloodborne diseases now, and so why can she not donate now?
So this is what we would do in session, and this is a really good example of what we would do. So on session, we all have phones, and this is how we access JPAC. So JPAC on the phone. It's donor selection guidelines, so we would just go down to and it's malaria. So
do you know why this is, what this is based on though? So what the JPAC get their guidance, but what is it specifically? Do you know why they've said that actually, you know, because obviously if it's malaria, they've said you can't donate for X amount of time, or you can't donate ever again. Do you know why that is?
it's normally 3 years for malaria. That's why I wanted to check, because I don't know why it would be a lifelong ban. So if you do have malaria,
I wonder if it's because she specifically outlined it was cerebral malaria. So I wonder
Right.
then if that has a different impact, because obviously then it may reside in your cerebral fluid a lot longer. There may be ongoing impacts for you and your health and well-being. So although it doesn't affect you on a daily basis, the ability to donate, I'm kind of spitballing here, but you very specifically mentioned it was cerebral malaria, so that may not follow the usual malaria guidelines.
yeah, so for nurses on session, that would be a referral to a consultant. It's not in our guidelines there that we can answer, so it would be a referral through, because malaria is a 3-year deferral from being well. So yeah, maybe thank you, Sam, for that. It would be something that would have to be referred through, but that does make sense.
I think ultimately, I think the bottom line, and I'm no specialist on this, but it's all about ensuring that the blood is safe for the patients at the end of the day, and safe for you to donate. So either one of those things, if there's any risk involved in potentially the safe kind of delivery of that blood, or you know, your safety and your health and well-being, then they are going to refuse it. So the best thing I can suggest to those of you that want to go out and donate and have been refused previously is to phone up and check before you go in, or there's an app that I use all the time just to check that I can donate for that time, and then go from there, so that you're not wasting your time when you go there and get refused, because I know how frustrated people can feel with that. But thank you very much for that. I've just got another question. Sam, if you wouldn't mind answering this one. It is, someone said about, if you're unsure of your blood type, can you still donate? Now, I feel like I can answer that. That absolutely, you can absolutely, you don't need to know your blood type. They will work that out for you and let you know what your blood type is. But any blood is welcome. So that was from Demi. And there was a question about naturally. So and I think, Cheryl, you touched on this, but if a patient needs a blood transplant, but they naturally produce too many red blood cells. So Sam, I did throw that one to you. So
Yeah. So I think possibly it's very specific in the context, and every decision is different. What I'm interpreting here is potentially, if you've got too many red cells, you shouldn't need a transfusion, essentially, because you've got enough red cells. What is probably happening is that your body, or the patient's body, is making so many red cells so quickly, there's not enough hemoglobin. So you've got the vehicle, but not the engine, in which case you shouldn't be given a transfusion for that. It's not blood they need. It's not donor cells they need. They need iron. They need the vehicle to make, they need enough of the raw materials to make enough hemoglobin and boost their hemoglobin levels. And again, it may be that there's a need for venesection to remove the cells that aren't useful, to slow that process down, so that instead of having lots of cells diluting our bloodstream that aren't functional, we've got good quality cells that have got the hemoglobin in that can do the work. So you wouldn't transfuse somebody for having too many red cells. You'd be looking at other therapy options.
I think to add to that as well, Sam, I mean, correct us if I'm wrong, but my understanding is that your red cells have around about a 6-week life cycle.
Yeah, about 31 days.
And if you have too many adolescent cells, that they're not functioning as well as what a kind of grown-up red cell would be, and that can cause difficulty for patients as well.
Yeah, so it's the adolescent cells won't have that functional hemoglobin unit. They won't have that bit that does the work. They're just they're a chocolate teapot. They're just an empty cell that doesn't function, and they just get in the way. So yeah, absolutely spot on. And it is they you know, our red cells have a short lifespan, around 31 to 35 days. So
thank you very much. That's really helpful. Just another couple of questions that's come in. What could be done to decrease the risk of infection for donors, please? I don't know what kind of infection, Natalia, you're referring to, but is there anything specific you can think of, Cheryl?
So the infection risk for donors coming in to donate would be primarily from the venipuncture site, and it's a completely non-touch. You can't repalpate. We clean the area with Chloroprep for 60 seconds, and you aren't able to repalpate. So it's very sterile, and sterile dressings are used. We do recommend you keep those dressings on for 6 hours, so you're not exposing that site to anything that could potentially cause an infection.
Thank you. And just one last one before we move on to plasma is why, do you know off the top of your head, either Sam or Cheryl, why you can't donate blood if you've received red blood cells, you know, in a kind of 10 to 15 year period?
So it's lifelong. If you've received blood in the UK since 1980, you can't donate blood. And the reason for that, again, Sam, please jump in and correct us if I'm wrong, but is because we have no testing for CJD. So CJD was introduced into the UK in 1980, and the only way to test if someone has that is post-mortem. So that can't be tested on your blood while you're alive, basically. So just to completely reduce the risk of that being passed on, and like Amy said, no risk is worth somebody's life. So we just say once you receive blood, you can't give blood for that reason.
Thank you very much. That's helpful. I think there's one other. This is quite a good question. How long can blood products be stored in various stages of the supply chain?
So red cells, as Sam said before, have a relatively short lifespan. So again, Sam, correct us if I'm wrong, but I believe we can use them up to 30 days, 35 days from donation.
I think once they're in your hospital lab fridge, you've got 30 days, I think.
30 days.
Yeah.
And then the other products, so you probably heard of fresh frozen plasma. That can be stored for up to 3 years, frozen. And platelets, I would have to check. I'm not sure on platelets.
Okay. All right. Hopefully that answered. Oh, sorry.
Just to say, there are different timescales once they get to your hospital lab, though. So you wouldn't find a hospital lab with a 3-year-old frozen bag of platelets. No. There are different rules for your hospital laboratories.
Yeah, that would be in the bases that I said earlier on, where the emergency collections would come from. They can store those products for that long.
Yes, yeah.
Perfect. Okay, thank you very much. Now we're going to move on to Claire Tranter, who's going to talk about plasma for medicine. Again, very similar donation centres that we have. We've got 3 sites at the moment, but it may be that's going to expand. But at this point, I'll hand over to Claire. Thanks, Claire.
Great, thank you. Hi everyone, I'm Claire Tranter. I'm a specialist nurse in plasmapheresis or plasma for medicine. I've been with NHSBT for 3 years now. I joined during COVID and joined the specialist nurse team supporting donation centres with the convalescent plasma programme, which was researched to see if giving people with COVID, who were suffering with COVID, plasma from patients who had recovered from COVID would help their recovery, if that makes sense. A lot of recoveries in one sentence. Our journey evolved somewhat after COVID, and I'll present that in a moment. But now I'm part of a clinical nurse leadership team in the new directorate, which we now call Plasma for Medicine. Okay, so you can go to the next slide. Thank you. So plasma for medicine. I would guess back a slide. That's it. I would guess that the majority of people on this call probably haven't heard of us and what we do, and this is because the directorate is only around a year old. It is really new, and this provides lots of exciting opportunities, particularly for our nurses, and it's a really exciting place to be at the minute. Or I think it is, and I'll tell you why. But before I go on to the roles of our nurses, I think it's important to understand a bit of the directorate of plasma for medicine. Next slide. It's a mouthful, plasma for medicine, especially when you're a little bit nervous about presenting. So why plasma and why now? So when I usually do presentations like this, I often assume everybody knows what CJD or mad cow disease is. And as I was preparing for this presentation, I realised actually, given the average age of students nowadays, some of you may not actually know what it is. So CJD was a devastating bovine disease that started in the 80s, and it was at the peak in 1990s in the UK. So why am I telling you this? Well, apart from this being devastating to those who had it and the farming industry, it actually meant that UK stopped fractionating plasma when the concern arose that it could be passed on through blood products, and that we might actually be able to transmit the disease, a bit like what Cheryl was saying just before. It was done as a precautionary measure until the science became a bit clearer. But in 2020, NHSBT welcomed the decision by ministers to lift the ban on UK plasma for fractionation following a review by the Medicines and Healthcare Products Regulatory Agency and the Commissions on Human Medicines. UK plasma was again deemed safe to use to produce these plasma for medicines, which are called, the ones that we're interested in is the IVIG therapy. So these are immunoglobulins, and I will talk about those in a bit. So why are we suddenly interested in it? There's a global shortage of IVIG therapy, and the UK needs to become more self-sufficient as possible. So now the ban has been lifted, we can start building this new programme, and it will keep growing in the future, hopefully. Next slide. Thank you. So I've spoken about the measures that have been lifted, but some of it won't make much sense without what I'm going to tell you next. So what is plasma? I'm sure you've all heard of it, and I know the science behind it, but why are we interested in it and what can it do? So plasma is the yellowish liquid in your blood. It carries the platelets, red blood cells and white blood cells around the body, and plasma makes up approximately 55% of your blood and contains antibodies known as immunoglobulins, which fight infection. And the focus of the new Plasma for Medicine Directorate is to take these antibodies from the plasma donations by a process called plasmapheresis, and then they can make this into medicines to help people with rare diseases, immune disorders, genetic conditions. Next slide. So medicine derived from plasma help over 17,000 patients per year. This medicine can be life-saving, but it also helps many patients by improving their quality of life. And without it, they can become extremely unwell. The medicine is called IVIG therapy, and some of you may have come across patients that rely on this drug, particularly patients who are immunosuppressed in cancer care or haematology, but also in rare genetic conditions and infectious diseases as well. You can see a list on the screen of how these sort of pan out number-wise. So as I mentioned briefly before, there's a global shortage of IVIG. We fully rely on other countries to supply these medicines to us, or to sell us these medicines, to be more accurate. Unfortunately, with the supply problems, this has meant patients have been going without the recommended dosage, some having their treatment halved or not given as frequently, and obviously this affects their quality of life. COVID has shown us that we need to become more self-sufficient, and with the ban I talked about earlier being lifted, we are hoping to be initially 30% self-sufficient in the coming years, but ultimately the goal is to grow the programme and open more donation centres across the country, and to hopefully one day be completely self-sufficient, although this will take many years. Next slide. Thank you. So Cheryl actually really explained the donor journey really well, and our donor journey is also based on the blood donation model. So I'll not repeat everything that Cheryl said, because then you'll be doubling up on the learning. But we have a brilliant base of long-term donors who have been with us since COVID, but we are getting new donors in all the time as well. Our nurses work really hard to ensure our donors are getting excellent customer service, and this keeps them coming back time after time. And we have some that have been with us from the very beginning. So like I said before, Cheryl has also already explained the donor journey and donation process for blood, and for plasma it is almost identical, other than the procedure itself. So I'll not duplicate and repeat it. Unfortunately, plasma donation is a bit more time consuming than giving blood. So most of our donors have to be able to give around an hour for an appointment. The plasma donation can take anywhere from 25 minutes to an hour, depending on the individual's hematocrit level. So that's how thick their blood is, for those that don't know, and how good their vein pressure is, their blood pressure. All different things like that can affect even how well hydrated they are. It can all affect how long the donation takes. It is our nurse team leaders' role in our donation centres to ensure they optimise these donations to ensure product quality and donor comfort and satisfaction, and they can do that through the machine. Oh, we've jumped a slide. So we're on it. Go back to the donor one. Back one. That's it. Thank you. No, that one. Our donors have to weigh at least 50 kilograms and be over 5 foot. We've had a small amount of donors who have been shorter than this, but the majority are over 5 foot. They need to have a very similar criteria to what Cheryl told you in the previous presentation. So fit and healthy, good HB within specific ranges for men and women. They also need to fill out the donor questionnaire to ensure they're eligible, and we also take samples just like blood donation. Occasionally donors will come who aren't eligible to donate because of their height or weight, and we coach our nurses to have those difficult conversations with them, as again, like Cheryl said, some people aren't happy that they've come and then they can't donate. But the nurses can, you know, they have coaching about how to be sensitive around these conversations, and they can administer sort of general health and well-being advice as well. Our donors have all sorts of reasons for donating, such as family members or friends needing IVIG, but some came to donate during COVID and have just stuck with us, which is brilliant. We have even had nurses who administer the IVIG therapy in their clinics come and donate because they are acutely aware of the shortages, which is amazing, but I think you'll agree it's also quite sad that that is their motive, that they've seen it firsthand and feel that they need to give their own plasma to help their own patients. Next slide. Thank you. So how do we take these donations? So we do it through a process called plasmapheresis. It took me a few weeks to learn how to say my own job role. It's quite a mouthful. Specialist nurse in plasmapheresis is a bit of a tongue twister. Takes a bit of concentration to get out. So the definition of plasmapheresis is that it is a method of removing blood plasma from the body by withdrawing blood, separating it into plasma cells and transfusing the cells back into the bloodstream. So our nurses oversee the whole process from venipuncture to take down and support our HCAs throughout the whole donor journey. It's very similar to apheresis, if anybody has heard about that, and I know we're going to hear from the TAS team in a bit. In fact, it's the same process really, but just because we take the plasma for medicine and then send it off to be fractionated, and that's what gives it the name of plasmapheresis instead of apheresis. So very simply, blood is drawn from the donor, goes through the plasmapheresis device, mixed with some anticoagulant, and the plasma is saved and everything else goes back to the donor. Next screen, please. Thank you. So on the screen is the plasmapheresis device we use in NHSBT. It is called the Fresenius Kabi Aurora. It looks complicated, but it is actually a really easy device to use once you're trained. Training usually takes around a couple of weeks. Our nurses and our HCAs are put on a 2-day intensive course, with the nurses also having a 3rd day to learn about alerts and alarms and how to deal with those. Then with about 2 weeks practice, most staff are ready to use the machine independently. As I said previously, the procedure itself takes between 25 to 55 minutes, depending on the donation particulars. And we're only allowed to process 16% of the donor's blood volume at any one time. So that means 16% of their blood volume can be being processed in the machine at any one time. So it's really key that we get their height and weight right, so that we're not taking any more than 16%, as that could make them really poorly. Because all the red cells, so because the blood, it's hard to show you when the machine's not running, but because the blood goes in, it goes around all the different pumps and goes into the little spinner, filter spinner. We take the plasma and then the red cells are returned to the donor. And because the red cells are returned to the donor, it's not like blood donation. You can actually donate every 2 weeks if you want to. And because you get all your red cells back, we're only taking the plasma, and that most people can make their plasma back within literally a couple of days. So next slide. Okay, so it's a blank screen at the minute, but I'm just going to show you, hopefully it's going to work, a little video about how the plasma is separated from the whole blood. It's really a simple process. Yeah, if you press play, hopefully it'll come up. So you won't be able to hear the sound on the video, unfortunately, but basically what happens is the blood is going to go into the machine. So the blue bit is the blood. It gets spun round, and then there's little microns in the filter, and only the plasma can get through, because they have a different weight than the red blood cells and the white blood cells. So only the plasma goes through. Oh, it's going a bit slow, but it's all right. So as you can see, the white cells in what's supposed to be red goes back to the donor, and we collect the plasma. And it really is that simple. That's the way the Fresenius does it. You can also do it by way of centrifuge, which is another spinning device, but it doesn't have, it just separates it. So the plasma goes to one side, the red blood cells, and the plasma comes out the top. That's very similar to a cell saver, which some of you might have seen if you've been working particularly in surgery or obstetrics. There's no better way, it's just the different systems work, and we use the Fresenius. So you heard me say fractionation, and to most of you that won't mean anything. It didn't mean anything to me before we went into plasma for medicine. It's a mechanical process. Once we have collected the plasma in the centres, it goes away to be frozen. We store it, and then we send it away to a fractionator. There they sort of they defrost and pool all the plasma together, boil it up, and they take out the albumin and the immunoglobulins, which is what NHSBT are interested in. It's actually a very complex procedure. They don't just boil it up, they add lots of different chemicals, but it would take me forever to explain the full process. So that's it in base. You can Google fractionation of plasma if you have an interest in it. There are lots of videos, and it is actually quite interesting once you get into it. But we don't do that within NHSBT. So it goes outside NHSBT to do that. Then it's made into medicine, and then the medicine then gets sent back into the NHS for our patients. So hopefully that was a bit of a whistle-stop tour on PFM. It is really quite simple once you get into it. But let's have a look at the different nursing roles within our directorate. So if you go to the next screen, brilliant. So this is our Birmingham team. So we have 3 centres. We have one in Birmingham, one in Reading, and one in Twickenham. I know that most of them are quite southern, or we did have some northern centres through COVID, but just initially in the startup of the programme, we kept the 3 centres in the south for various operational reasons, but we're hoping to expand back into the north in the future. So on the screen, this is the Birmingham team, and this is who you would see on a typical session. And again, very similar to blood donation, if not the same, really. So we have our plasma operations manager, and that is basically like your lead practitioner on a ward. So he takes care of the centre or the operational extras that come with that role. We then have our healthcare assistants who do the majority of the donor care on session, the hands-on donor care. And we have our session sisters. And again, they are very similar to, well, they're exactly the same to BD. They do the same role. We actually call them our nurse team leaders, but I've just put session sister on here because most people know what blood donation do, but ours are nurse team leaders. And then on here as well, we've got a specialist nurse like myself, and there's 4 of us in our directorate. And I'll talk about our role in a bit. You wouldn't see us on session every day, but we do have a lot to do with the teams, and we like to go and visit and see how things are going. Excuse me. Right. So, nurse team leader. All of our nurses are band 6. And we don't have any band 5s currently. And this is because of the accountability and the session management role that they play on session. Our nurses all embark on an induction programme that is really similar to blood donation. And the only extra is that our plasma nurses do differently from BD is they actually do venipuncture. So as Cheryl said before that their nurses don't, our nurses do. And the HCAs do the majority of them, but our nurses can also complete the venipuncture as well. And it takes a nurse around 8 weeks to complete their induction and to be safe for independent practice. So I think I missed a slide actually. I think that was a different slide, but we'll go on to this one. Go forward again. No, I've missed a slide out of this slide deck. That's unfortunate. It's all right. You can go back to the other one. Thank you. Thank you. Sorry. So this is quite a long slide, so just hang in there with me. So again, our nurses do more or less what the BD nurses do, the blood donation nurses do. Our band 6 nurse team leaders lead the day-to-day management and performance of the plasma collection team to efficiently and safely deliver sufficient plasma to meet collection programs needs in line with regulatory clinical requirements and the operation performance standards. Bit of a mouthful. They ensure that a great donor experience is at the heart of everything they and their team do, with the ultimate aim of building donor loyalty and retention. And people often ask why all our nurses are band 6, and this is simply because of the responsibility and accountability they have on session. Day to day, you will see our nurses on the session floor assisting with the session and general management of the team. But outside of this day-to-day role, their responsibilities also include ensuring the plasma product safely meets the requirements of good manufacturing practice. And they also need to ensure the team follow instruction on clinical and standard operational procedures. And they provide expertise on donor eligibility and clinical decisions, overseeing the guiding the team through all aspects of collection process and the donation journey. We also use JPAC in plasma, which was what Cheryl was using before, so it's all the same process. They will manage, investigate and escalate any risk or adverse safety incidents, and they're also required to act as a role model, driving change and improving service delivery and safety through inspirational leadership and performance management to ensure the team follows standard operational procedures. I think I may have already said that, I'm sorry. We actively encourage our nurses to be role models of desired behaviours to create a culture of inclusivity, listening and respect for the colleagues. And our nurses also can deputise for our plasma operation managers in their absence. So what does a typical day look like for one of our band 6s? They will firstly lead a team brief at the beginning of session to set up the day and delegate the various daily tasks to members of the team. They will check everything is in order for the session to start and end safely. They are then present on the donation floor for the session. They will answer any what we call queries, like Cheryl was doing with the malaria. That would be a query that they would deal with on session. And they will also support the HCAs with any deferrals or any problems with donors, such as like irregular heart rates or low or high HB, things like that. They are also the only members of the staff on session who can deal with fixing an alert or an alarm on the Fresenius machines, because sometimes, you know, things do go wrong during the donation, and they need to act on those. This could be that the flow rate needs adjusting, or sometimes you can get little air bubbles in the system that need to be purged, so that they don't go back to the donor. They would also lead on treatment of any adverse events such as faint, bleed or citrate reaction, but they also need to be trained in things like basic life support and coordinating the care of the donor if they become unwell on session, which can happen. And it's not always to do with the donation. Sometimes people come in feeling well and then they can become unwell. So our nurses deal with all those things. On top of this, we'll fill in any quality incident paperwork should the need arise on session, and also facilitate training and mentoring of staff. They complete the staff rotas and answer any donor complaints, anything like that. They're busy bees. Okay, next slide. Okay, so here's Mark again. He's our plasma operations manager in Birmingham. Again, it's more or less like a lead practitioner that you would find on your ward. Currently there is one per centre, although all three of them work really close together to ensure consistency across the centres. And they're ultimately responsible for everything within the centres, ensuring the directorate and organisation's operations run smoothly and on time. And they are responsible for budget, service improvement and delivery. And they're also responsible for engaging and developing the members of the team. They manage, including sort of hitting the training targets, staff appraisals, things like that. Everything you'd expect your lead practitioner to do, our plasma operation managers do. Okay, next slide. Last one, we're nearly there. So this is Kim. She is one of our specialist nurses. There are 4 of us. The others are called Ruth and Wayne. And we are spread across the country. So our role is national, although, as I've explained before, we've only got the 3 centres in the south. On the role I play, so I work alongside these specialist nurses, and our main role is, as our title suggests, really, we're the specialists, we're the experts in plasmapheresis donation and the donor centre plasmapheresis activity. And we spend around 20%, or we try to spend at least 20% of our time in the donation centres, and working alongside the plasma operations manager and the nurse team leaders, and providing support, guidance and advice on ensuring donor care and management is delivered to the highest standard. We're responsible for reviewing and updating practice and associated control documents. We work with the nursing head of plasma and support hub lead, validating, procuring and implementing the new equipment. And we supported the validation of the Fresenius Aurora, for example, when we switched to this machine at the beginning of PFM. Plasma for medicine. We work to ensure established systems and processes are fit for purpose, identifying areas for improvement or redesign in order to promote best practice in relation to plasmapheresis donation, whilst ensuring product safety and regulatory compliance. And working collaboratively across all functions within NHSBT to define and embed best practice, whilst upholding professional standards and donor care standards. We are responsible for the clinical content of all training related to plasmapheresis, and we also train our new staff as well, our new nurse team leaders. We regularly lead on clinical audit, report on findings and develop action plans to implement the recommendations from that. And part of our role is also to provide expertise to research groups, and we also participate in clinical governance, quality incidents and service improvement. So we do quite a lot, but it's a brilliant job. I'm really enjoying it. My background is actually theatre recovery, so I came out of an acute trust straight into this, and it's great. It's a great place to work if anybody is thinking about it in the future. So that's actually the end of my presentation. I don't have an end of presentation slide, I don't think. Oh, I do, look at that. So Plasma for Medicine. So in summary, Plasma for Medicine is brand new NHSBT directorate that will expand in the coming years, and plasma is collected, fractionated and then administered to patients as IVIG therapy or albumin therapy. So yeah, so that's us, that's the directorate. Please feel free to reach out if you'd like any further information in the future. Thanks for listening, and I can take any questions if there is any.
Thanks, Claire. Well, there is one question here. So, can you donate plasma? Actually, I would quite like to know this. Can you donate plasma if you're anemic?
No.
No.
So
okay.
it's the same. Yeah.
Right. Okay.
That's
fine.
an easy one.
Yeah.
Yeah. So
okay.
you still have to have. So we do like BD. So even though you're getting your red blood cells back, you still need enough red blood cells to be healthy. So we still check your hemoglobin when you come onto session, and you have to sit within the parameters for that. So yeah, no, sorry.
Thank you very much. Thank you very much. That's very helpful. In the interest of time, I would like everybody to have a break and remove away from the screen now. When we come back, if we come back in about, but for 12 o'clock if possible.
You're on mute.
Yeah,
Yeah,
no, someone muted. Fed up appearing. So yeah, so if everybody could come back at 12 o'clock, that would be really helpful, and then we'll hear from our organ donation nurses and hopefully have you all finished by 1. But keep the questions coming in. All right, thank you very much. See you shortly. Hello, everybody. Just wait for a few more people to come back, and then we'll make a start. So we're going to hand over now to Sam Halcrow. He's one of our organ donation specialist nurses, and she's going to talk you through the process and actually the day-to-day of what they do. We've got about, I would say, about 500 organ donation nurses around the country that work in all of our hospitals, or embedded in all of our hospitals across the country. So you may or may not have come across them when you've been working in intensive care units and such like. So I'll now pass over to Sam and welcome you, because you are actually at a conference, aren't you, Sam? So
I am. Thank you very much for inviting me. So yeah, just bear with me because I am at a conference and I've had to just find a quiet corner to present from. Can you hear me okay, Amy?
perfectly well. Yeah, really well.
Wonderful. I will just share my screen with, oh, you've got it up already. You are organised. Thank you. So as I said, I'm Samantha Halcrow. I'm one of the specialist nurses for organ donation in the Yorkshire team. So I'll just, can you move on? Are you moving on for me, Amy? Oh.
No, Bethany is.
Oh, I'll move to the next slide if that's okay. So hopefully by the end of this session, you'll have a bit more of an insight into organ and tissue donation and the role of the specialist nurse. I'm going to provide you with a little bit of an overview about the process and give you some understanding of what a student nurse placement can bring as well to those students. So as part of our role as specialist nurses, it's a lovely title, SNOD. So it's specialist nurse organ donation. We cover a 24-hour, 7-day-a-week service, which consists of different shifts, which I'm not going to go into, but on-call shifts, and we do long shifts, 12-hour shifts, and early release shifts to take over from the people that have been out overnight. So there's two elements to our role as specialist nurses. One, there is an on-call element where we will assess a potential patient suitability for donation, and we're there as a support for staff, patients and the families through the whole process and pathway of donation. And we're there to implement and provide donor management advice as well. And then we do have a wider role within NHS blood and transplant. So we all have individual national and regional lead roles. I'm part of a coroner working group, so I'm involved in any changes that go on nationally in terms of coroners. We're there to increase the profile of organ donation and promote that. We work quite closely with clinical leads for organ donation, who are usually anaesthetists that are based on intensive care units. And there's oh, sorry, there's just some interference. Someone gone off. Oh, thank you. Yeah, sorry. So we work with the clinical leads for organ donation. We have link nurses around intensive care units, A&E departments and theatres around the country, and we're part of an organ donation committee in the trusts that we're based in as well. And we have to actually report back to those trust boards about the organ donation figures and performance. And to do that, we have to audit all deaths within ICU and A&E around the country as well, to check that there's no potentially missed patients that could have been referred. So a bit about who's who and whereabouts. So as I said, I'm part of the Yorkshire organ donation team, and there are actually 12 regions around the country, and we have 28 hospitals that we look after. So we cover Yorkshire and Northern Lincolnshire. We work as part of a cluster in which there's 4 clusters in the UK, and we're part of the Great North Cluster, and you can see on the map there the different clusters around the UK. So as part of our team, we are based in Barnsley. We have an NHSBT office in Barnsley, which consists of a head of nursing, and we have 3 lead nurses, which are like matrons in the normal NHS. We have an educator, and we have 15 specialist nurses for organ donation. and 8 specialist requesters. So there's a slightly different role, those two. The specialist requesters tend to work 3 12-hour shifts, and they go and speak to families initially before the specialist nurses go and take over and continue with that process. So in terms of the experience required to become a specialist nurse for organ donation, historically, you had to be from a background of ITU or ED, but this is now evolving. They are taking backgrounds from bereavement areas, hospices, backgrounds like that. And I am actually from an A&E background, which the majority are from ITU, but I was a sister in A&E for 10 years before doing this job, and I'd not actually had much experience in donation, but it was something that I've always been keen to progress in. So I was actually the link nurse in ED, so I did have that involvement in organ donation. We usually ask for experience in leadership, and it is a band 7 role. And when you get that role, you have 6 months of extensive training, which is supernumerary for 6 months, which I know in the wider NHS it's difficult to have that. But we're very lucky in having that 6 months of training. So a bit about why we need organ donation. So every day somebody dies waiting for an organ transplant. There's currently about 7,000 people on the active organ transplant waiting list, 200 of which are children. And in fact, over 90% of the population say they support donation, but there's only about 27% that are actually on the organ donor register. And I think a lot of people don't know, and I didn't coming into this role, that you're actually more likely to need an organ than be in a position to give one. It's quite a rare situation you have to be in to be an organ donor. So each organ donor can actually save the lives of up to nine people, which is quite incredible. So in terms of the patients that we get referred for organ donation, it is part of NICE guidelines, and we're hoping, and it is becoming more common, that it is part of usual end-of-life care planning, and this is what we're trying to instill in the units across the UK. And we want people to identify the patients that are potentially suitable donors as early as possible, so we can come and do that background work. Obviously, we cover a large geographical area, so it also helps us to arrange where we're going to base ourselves around the region. So the triggers for that referral are someone that's potentially going to have neurological death tests performed, or a patient where that life-sustaining treatment is going to be withdrawn because they're not going to survive this episode of illness. So as I said before, it is very rare that you're in a situation to become an organ donor, and this just shows that pool of people in the country. So out of 100,000 deaths, there's actually only just under 1,400 that become donors. So it is such a small pool of people that can become donors. So you have to be dying on a critical care area, and they have to be intubated and ventilated. So that diagram just points out how many people can actually become donors, and that's why it is so important that we offer donation to all those appropriate families. And we know that donation isn't for everyone, but we as specialist nurses are there to give the core information that's needed for that family to be able to make an informed decision about their loved one. So I'm just going to touch on this, which I'm sure a lot of you will have heard about, but unfortunately the new legislation changed at the same time as COVID. So the media was surrounding COVID more than it was the new legislation coming out. But it changed in spring of 2020. And if you haven't made a decision on the organ donor register, then we would class that you have deemed your consent if you've not opted out for donation. So it isn't for anybody to be concerned about when referring a patient. It is for us as a team to assess. But things that we will look at are patients have to be over the age of 18. And we assess whether that patient has got the capacity to make that decision in life. And it has to be people that have been living in England for over 12 months as well. But those are just some of the criteria that we look at when we're assessing a patient. And I know as nurses and healthcare professionals, it's not something that we like to think about really. That isn't our aim. With our roles, but there is a financial implication in terms of organ donation as well. So just as an example, this slide shows that for renal recipients, the average cost of dialysis for each patient each year is about £31,000, and a kidney transplant costs about £17,000. So in the long term, we're saving the NHS about £5,000 a year post transplant, which in this day and age as well is a considerable amount of money, and we need to be thinking about that as well. So I'm just going to touch on the different types of donation briefly. So obviously you'll have heard of live organ donation. That's from one living person to another, and mainly that is in relation to kidney donation, and sometimes people can donate part of their liver as well, but that is a different team that deals with that. That's not our team. The main types of donation that us as specialist nurses take care of is DBD patients, so donation after brainstem death, where they're having neurological death tests performed, or donation after circulatory death, which is DCD, and also tissue donation, which occurs after death when the patient is actually transferred to the mortuary. So this slide here shows you the different types of tissue donation that can occur, and as I said, this is where a specialist team will come to the hospital after that patient's died and they've been transferred to the mortuary. If we are involved in terms of organ donation, then we will take consent for tissues as well. But otherwise, it is a different team that deal with tissue donation, and they will carry out those conversations and that consent with a family over the phone. So these are the organs that can potentially be donated from the patients that we look after. The ones at the bottom are more uncommon, but they are potentially, but they're quite novel transplants that occur. It is quite rare, but these are the solid organs that can be donated that you can see here, so that a heart, lungs, liver, kidneys and the pancreas are the most common ones. So when we receive that referral as specialist nurses, we make a baseline assessment of that patient, and if we're unsure about how appropriate that patient is, we will speak to our transplant colleagues as well and gain their input. We'll check that organ donor register to see if that family, that patient, have registered a decision on there at all before we speak to a family, and we will attend that potential donor and continue with that assessment before speaking to a family. We will then approach that family about donation and potentially gain consent for that. There's no fixed timescales in how long that will take, so we can sometimes be involved for 24 hours before we would even mention donation. a lot of the time are involved in those initial discussions with families to tell them that their loved one's not going to survive this episode of illness, along with the medical team on the units. And a lot of our 6-month training is based around our communication with those families. It's obviously a very delicate subject and very emotive, and you're meeting these families at the worst possible time in their lives. We would never mention donation if we didn't think it was the right time for that family. So we will always assess if that family are accepting of futility as much as they possibly can and are accepting of that situation before we speak to them about donation, which is why it's best that we are involved. We don't want this being mentioned in A&E, it's not appropriate, and we want to give that time to the family to process what has happened before they've got anything else to think about. So we're able to give that family that support beforehand as well. And as I said before, we're there to make sure we're giving that family all the information they require in order to make an informed decision. So if we gain consent from that family, then there's a long process, which I'm going to touch on briefly, about what happens next. So we will review that patient's past medical history right from birth. We will speak to their GP. We also carry out a lot of questions with the loved ones, with their next of kin, about the medical and social history to check that there's no issues going forward for any recipients. And obviously we're doing all this to the best of everyone's knowledge. We never know everything about a patient, but we're just minimising that risk for recipients. We will also carry out a head-to-toe assessment of that patient. We will take blood samples which are sent off for tissue typing, which will help us try and find suitable recipients around the country. And we'll also test for blood-borne viruses. And we're also providing advice to that unit to try and optimise that patient and make sure that their wishes are honoured in becoming an organ donor. So I'm just going to touch on the 2 types of the pathways in terms of organ donation, just to give you a little bit of an insight. I'm not going to go into it in too much depth. And if you have any questions, I forgot to say at the beginning of the presentation, please just put them in the chat box or put your hand up. And I know it's quite an emotive subject and people might have their own personal experience of donation. So please just put it in the chat box or leave, or have a moment if you need to at any point. So the DCD pathway, which is donation after circulatory death, is when, as I said, that treatment is going to, of life-sustaining treatment, is going to be withdrawn, resulting in that patient dying and their heart stopping. So this decision has usually been made by 2 senior doctors, that it's no longer in that patient's best interest to continue that care. Sorry, not care, treatment. The care will obviously stay the same. And the decision will have been made not to resuscitate that patient if the heart were to stop. And just to add, the process up until this point, really, and up until theatre is very similar. We gain all that the same information, and everything's very similar throughout the beginning part of the process. So once all that information has been gathered that I talked about, then we will wait for, so we will mobilise a specialist team of surgeons, which I'm going to talk in a bit more detail about shortly. And we will have, as specialist nurses, handed over that patient to the surgeons on their arrival to the hospital. And when they are ready and in theatre and that they're all prepared for the operation, we will transfer that patient to the theatre complex, which is usually in the anaesthetic room, which has changed over a number of years. We used to withdraw treatment on the intensive care units, but we now do that in a lot more controlled environment, which is usually the anaesthetic room. And we prepare families through all our conversations about this and about the timeframes and about what will happen when it comes to the surgeon's arrival, so that they're as prepared as they possibly can for this moment. And the families can be there as well at this point in the anaesthetic room, to be there when that with their loved one when they pass away. So we will extubate a patient and withdraw that treatment like you would normally on an intensive care unit when everybody is ready. So as specialist nurses, we're coordinating that with the recipient centres around the country as well, because they obviously have to be ready with their recipients at the same time. So a doctor is who's qualified to certify death from the intensive care unit or the theatre complex is there to certify that patient having died at that time, and they will be there throughout that part of the process. And us as specialist nurses will relay any observations and communicate with the retrieval team and the recipient centres around the country at this moment in time as well. We try and take a step back so families can be with their loved ones. And again, we explain this communication as well to the families throughout our conversations, because we don't want to be in the way. We want to try and leave the families to spend that time with their loved one. So we wait a period of 3 hours for that person's heart to stop, and then the doctors that are certifying that death will observe that patient for 5 minutes of asystole before they certify death. And then when that death is certified, as you would normally in any area of the hospital, they will then be transferred into theatre for the operation to start. And the family will then leave and be supported back to the intensive care unit by the bedside nurse that has also been there, and they are responsible for looking after that family going forward. And then the operation will start. Just to add, if a patient doesn't die in that 3 hour time frame that we have, they will be transferred back to the intensive care unit for continuing end of life care, which again families are informed about before they even make a decision about donation. And throughout all the process, our priority is making sure that that patient is comfortable and that family are supported, and that is our priority, irrelevant of donation. So any medications to make their end of life care run smoothly can be given, irrelevant of donation. We are obviously not involved in that as an organ donation team. That is for the medics that are looking after that patient to decide. So that briefly is the DCD pathway, and then I'm going to move on to the DBD pathway, which is when a person has become, they were suspected to be neurologically dead. So this can be caused by lots of different reasons, and it's basically an irreversible rise in that intracranial pressure, which can be due to all those listed there. So from a traumatic brain injury, any bleeds in the brain, hypoxic brain injuries that can be caused by lots of different things, are just a few examples of the causes of brainstem death. So these tests are only performed if that death is suspected to have occurred already. And again, this will have been explained to a family, which is very difficult for them to understand. And again, we are there to support them through that understanding and those conversations about neurological death. So the tests are performed twice by 2 doctors that have been qualified for over 5 years, and one must be a consultant. And we always make sure that families are aware that the time of death that will actually be on that death certificate is the time when that first test was complete. And the tests are testing all those cranial nerves in the bottom of your head, in your brain stem. So irrelevant of donation, these tests are conducted because it's a diagnosis of death and it's a definitive answer for that family and for the medical staff. These, as I said, it's certified after the first set of tests are complete, and it's not just for organ donation purposes, and it leaves no uncertainty for everyone. It does, in the future, from feedback we've had from families, help families with that bereavement process, because they know there was nothing that could be done for their loved one and they had died. So when it comes to finding suitable recipients around the country, there's a strict offering sequence to ensure that there's transparency and equity to all. There's a super urgent waiting list and an urgent waiting list, and they obviously take priority because they are the sickest people waiting for those transplants. So every transplant centre gets 45 minutes to respond to that offer around the country, and some cardiac centres can actually have in excess of 25 patients just listed as urgent patients. So there's a lot of work that goes on in the recipient centres to look who would potentially be a match for our donors, and they then have to speak to their surgeons as well. So we have actually 8 abdominal retrieval teams around the country and 3 cardiothoracic teams, and it's called the National Organ Retrieval Service, who are commissioned specialist surgical teams that attend the hospital where your donor is, and that map there just shows the different regions where those teams are based around the country. I've spoken, with this slide, I've spoken about the DCD part of theatres and that withdrawal of treatment. So in terms of the DBD patient, when they've been declared as brainstem dead, it's very much like a normal operation that you would carry out. It's the patient is transferred on the ventilator with any continuing support, any inotropes, any medications, and we would check their identity, and we also have a moment of honour for both types of donors, but at different times in the process, where we just take a moment with the rest of the surgical team and the theatre team to just honour what that patient is about to do in giving the gift of life, and then we will start the operation. So these are just to give you an idea of how quickly those organs need to be transplanted in once they are retrieved. So we have a very short window of when those organs need to be transplanted, which is why we work so closely with the recipient centres around the country. So they could be going to Scotland, London, anywhere around the country. We also, so after the operation is finished, it is part of our responsibility as specialist nurses to carry out the final cares of that patient, and we can, any family that want to spend time with them after and take part in that, we can facilitate as well. And any special requests from a family that are personal to them and their loved one, we can also do, like we can put a football shirt on, we can play music during that time frame when we're carrying out those final cares. Anything that is a family would like, it's irrelevant of donation, we can facilitate that, and we carry that out, and then the patient will be transferred to the mortuary directly from theatres in most instances. And we do have a lot of follow-up with families after the donation, so we will give them an update if that's something that they would like after the operation, to let them know what organs have been retrieved. And again, not all families want that information. It's something that we discuss with them throughout our conversations. We also carry out bereavement calls a couple of weeks after the donation and their loved ones died, to signpost them to any bereavement services and just check in with them and check they've no questions. We also have an Order of St John's Award, which all donor families are invited to about a year after their loved one has died, and they will receive an award on behalf of their loved one. And we also facilitate any correspondence through recipients and donor families, that would all come through us. So in terms of student nurses and having a placement with the organ donation team, I think it's really beneficial. And we have had a few students recently that is quite new to the Yorkshire team, but the feedback that we've had is excellent and they've found it really beneficial. So obviously they're gaining experience in assessing potential donors and observing the whole donation process. They will gain experience in intensive care areas and theatres, and the continuously observing end-of-life conversations and breaking bad news conversations, and the use of those enhanced communication skills. And finally, we also take part in organ donation, teaching and auditing, so they will observe that as well. So I hope that has given you just a whistle-stop tour and a bit of an insight into organ donation, and just give you that understanding that it's a very complex process, but it requires teamwork throughout all the MDTs in healthcare. But I can advocate what a fantastic job it is if anyone is interested in the role, and I'm here to answer any questions if you've got any.
Thank you, Sam. That's really helpful. We've been asking people to put their questions through on a form, and I've got one here. Is a person able to perform the daily base activities after donating a liver?
Yeah, we don't have much to do with the recipient side. So there's recipient coordinators based around the country. And obviously there's different outcomes for liver recipients, but yeah, we run study days as well, and we have recipients that come and speak on those study days, and it's absolutely incredible to see their lives transform and how they go on to live a healthy life throughout after donation.
Thank you. And there's one just in the chat. If an organ donor wants to donate their organs, they can have input on, can they have any input? I'm assuming that's this person's asking on where their organs go, either to a child or an adult.
No, so it's altruistic, the donation process. There's no way of requesting where those organs go and what recipients receive those organs.
Thank you. Thank you so much, Sam. That was an absolute whistle-stop tour of organ donation. We could probably spend a week just learning about the ins and outs of that. And as Sam said, it's a 6 months training period for any nurse coming in to do organ donation, just so you're aware. But do, if in your local trust, do seek out the organ donation nurses, usually buried somewhere in an ITU. But if you want to know more, obviously do let us know, and we can have a conversation. And there are, like I said, organ donation nurses across the country. Thank you very much, Sam. We'll let you get back to your conference now.
Thank you. Enjoy the rest of your day, everyone.
Thanks,
Thank you. Bye.
So now I'm about to welcome Teresa Baines, who is our Head of Nursing for Therapeutic Apheresis in NHSBT, to do our final overview of a very specialist group of nurses that we have across our country again. So I'll hand over to you, Teresa.
Thank you very much, Amy. It's a pleasure to be here. So this is the final session today, so I'll try to keep to time. So as Amy said, I'm Teresa Baines. I'm the Deputy Chief Nurse for Clinical Services, but I head up the apheresis team for NHS Blood and Transplant. Claire Gilson was going to join me today, but unfortunately she's not able to do that. So what I'm going to go through today is going to talk about our service, the procedures that we are able to give, the role of the nurse in the service, and what experience qualifications you need to come and work with us, and the training and preceptorship and career opportunities. So background it has. So we originated in the blood donation team, but we developed medical and nursing interest in collection and therapeutic apheresis, particularly for bone marrow transplant originally, and we became part of teams within hospitals supporting their transplant services. But we became an independent function in 2008, and we now have units that are embedded within acute trusts. And TAS provides therapeutic and collection apheresis services across England and into Wales. I'll go into more detail later, but we're now approaching about 11,000 procedures a year across our units. And we are part of NHSBT's cell apheresis and gene therapy function. So this is where our units are located across the country. We're in 2 locations in Liverpool. So we're in the Royal and in the Clatterbridge Cancer Centre, but we do outreach to other hospitals within all of our regions. So each unit can have up to 10 or 12 other hospitals that we will, our nurses will attend and deliver treatments. Our other areas are Manchester, Sheffield, Leeds, Birmingham, Oxford, Bristol and London. So you can see how many procedures we do in each of those units. Yes, thanks. And the percentage of outreach. So what patients do we treat? So adults and children. We mainly have adult nurses, but we do have some paediatric nurses working for us, but our adult nurses can treat paediatric patients with a paediatric nurse present. So we can exchange blood components or collect cells from patients. So we treat haematology patients, so mainly bone marrow transplant, neurology patients, renal patients, some dermatology and limited oncology. And then there's another scatter of patients, which I'll go through later in more detail. So this is how many procedures we now treat. So as I say, we're getting close to 12,000 we're predicting this year, but it's steadily increasing. And once we open our units, more and more hospital trusts realise that we are able to deliver treatments for them. So hence our numbers growing year on year. So our strategy within therapeutic apheresis services is to reduce inequalities of access to treatment for patients across the NHS and to become the preferred provider of high quality, cost effective therapeutic apheresis services. Now, we never want to destabilise apheresis services that are in hospitals, but we are able to give outreach treatments across to other hospitals that other large apheresis teams can't do. They're unable to move their machines and the staff. So that's why we're very unique across the NHS. So what is apheresis? So it's actually Greek, the word apheresis. It means to separate or taking away. So blood components are separated via centrifugal techniques that were developed from sort of the early 1900s when blood donation first sort of began to be able to split and fractionate the blood. And a very clever doctor, Dr. Edwin Cohn, back in sort of World War II times, realised that actually we could develop that fractionation even further. So during World War, plasma was given to soldiers when they were bleeding, but that came with high levels of infection. So years later, Dr. Cohn was able to separate even further, and that plasma could then be pasteurised. Very, very exciting. And in the 50s, a scientist's son was diagnosed with leukemia, and being a scientist, he knew that there was this technique available. So they developed it further so that we can then separate all blood cells. So it's in the centrifugal machine in the Cobe Spectra that was developed in the 80s. We can now separate red cells, white cells, plasma and platelets. So we can either collect them, remove them or exchange them. And it's a continuous flow. So like I say, the centrifuge is a bit like a washing machine. So the heavier cells, the red cells, will stick to the outside and the plasma is lighter, so it will stay on the inside with the white buffy coat in the middle, and then the machine's very sort of cleverly just draws off the cells that we need. You can also filtrate, so renal teams will do filtration similar to dialysis, and we do very few absorption, but if you have a hyperlipid disorder, we can absorb some of those lipid cells to prevent morbidity. So this is just showing the different components and the sizes of them and why they sit like they do in the centrifuge. So these are the numbers of procedures that we do. So plasma exchange is around the 4,000 mark, and I'll go into more detail about who has which treatments in further on in the presentation. Red cell exchange, stem cell harvest, the lipid depletion, photopheresis, and then we have patients and we have donors, which I'll explain a little bit more later. So our patients may need central access devices, planting, but the majority of our patients will have just a standard cannula. But these are the sites where central venous catheters are inserted. We don't tend to use PICC lines. They just don't have fast enough flow currently, although the power PICCs are being looked into. So the next slide shows examples of the ports. So some patients, if they're on chronic treatments, will need a port inserting underneath the skin. This can then stay in and it's just accessed via a needle. But like I say, the majority have a large gauge high flow needle. So which patients do we treat? So we offer a range of treatments to cover a multitude of disorders. So red cell exchange is predominantly for sickle cell patients when they're either in crisis, but preferably they come onto an elective red cell exchange program if they're severe enough. And what we can do is reduce the amount of sickle in their red cells, because those sickle cells can do a lot of damage to the body. We also treat patients that have had malaria and babesiosis. Then ECP is extracorporeal photopheresis, and it's given to transplant patients who have got graft versus host disease. So that's when the patients, the donated cells, see the patient as being a foreign object and fights against the body. So this is a really important treatment to reverse that effect. And then the immunoabsorption is just a special column. This DALI. We have very few patients across the country who need this treatment, fortunately, but it is there for those rare patients. Then plasma exchange is given to many patients across the country. They can also have IVIG, so where there is the reduction in IVIG across the country, as explained earlier by the plasma team, we can actually give plasma exchange instead. So many patients can fall under this category. So acute Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, this is all testing me now, myasthenia gravis, paraprotein peripheral neuropathy, and neuromyelitis optica. So what we do in plasma exchange is we take off, it's all the immune cells within the plasma. So by removing it and replacing it, takes away that immune response and gives patients, the chance of recovering from these disorders. So for renal patients, there's cryoglobulinemia, ANCA-positive vasculitis, hemolytic uremic syndrome, and renal transplant rejection. So some of these patients may be given plasma filtration, but the majority of renal teams do refer to us when they can. And then in the haematology setting, patients with myeloma, Waldenstrom's macroglobulinemia, thrombocytic thrombocytopenic purpura, TTP, and heparin-induced thrombocytopenia, HIT, are also treated. So some of these patients would not have any other treatments available to them if we didn't give plasma exchange. So we can give white cell depletion for patients with acute myeloid leukemia usually. And that's in very, very early stages of diagnosis when the white cells are really high and dangerously high. But we also collect stem cells for bone marrow transplant patients, and these for usually hematology patients who wouldn't be able to have chemotherapy strong enough to kill off their leukemia if we didn't collect these cells and able to rescue them. So that's what it is, a stem cell rescue in the autologous setting. That means the patient's own cells are collected and given back to them. They're stored in our CMT labs, so that's our cellular molecular treatment area, and that's another their scientific labs within NHSBT. And in the allogeneic settings, this will be an allogeneic donor, whether that's a sibling or from an unrelated donor, so Anthony Nolan or BBMR or DKMS. So they're the different registries around the country and Europe. And again, the same as being on the register for organ donation, you can put yourself on the register to be a bone marrow transplant donor as well. So we collect cells from whether that's siblings or unrelated donors. It's just a picture of our machine, a very dodgy picture, and some of our lovely nurses. I think there's a better picture on the next slide. So what might a placement look like? So some of our bigger units have student nurses come to visit them, and you're able to, work alongside our fantastic nurses and go out to different hospitals that you may not otherwise have the opportunity to. So you get to see all the different procedures and techniques and learn all about therapeutic apheresis. So if you come and join us in TAS, traditionally you came in at band 6 level, but we are now rethinking and have actually training nurse associate placements with us. And we are thinking about band 5 positions where you would come in and transition into a band 6 post, because we do train with, we bring people in as a band 6 and train them up in apheresis. So we have a clinical training period. It's a modular based training, so you'll have 2 separate weeks in the classroom with our educators. We use competency frameworks and ongoing annual CPD. We have very strict clinical guidelines and quality documents because we are highly regulated, NHSBT, and particularly with patients that we are treating. And we've now got the first ACP apprentices in NHSBT, so we've got 3 advanced nurse practitioners in training, which is really exciting. And we've just taken our first student nurse who's doing her training in the Hallamshire, but working for us part-time on a apprenticeship. So really, really exciting times for TAS. So what do careers look like in TAS? So historically, you would have just thought, you'd work on a unit and you could become a lead nurse for that unit, but it's so much more varied. Our education team is growing. We now have 8 educators across the country in a variety of specialties. We've got 2 ultrasound guided cannulation students, educators rolling out that training nationally. We then have our service development team, because of course we have to have contracts with other acute trusts to do to treat their patients. There's a lot of work in the background that goes on developing and initiating those relationships. So we've got 2 nurses within that team who play an integral part in that communication. And obviously we have majority of trained nurses, but we do have unit assistants and non-registered people working within our units that have gone on to do followed on to do their training. And I think that's everything from me. Tried to make it quick so you could have time for questions and close up.
Thanks, Teresa. That's really helpful. That's great. I don't know if there's any questions. If anybody's got any questions, you can pop your hand up, or I'm just looking at the Microsoft form. Like I said, we have about, as I'm sure Teresa mentioned, that we have about 100 plus nurses now, Teresa, working across the country in various different units, and either they're static units or they work out in hospitals and do procedures out in hospitals. So yeah, a very exciting job and a very specialist role as well. So
It is.
It is, and with a great leader as well. I'll just put that out there as well, Teresa.
Thank you, Amy. It's been really exciting, and it's been the most rewarding job I've ever had. So I came from a background of haematology nursing, bone marrow transplant. I've been a matron. I've worked out in acute trusts for all of my career. I trained in apheresis in the 90s, late 90s. So yeah, it's a really wonderful place to work, NHSBT. And as others have said today, you know, whoever you meet, you're always welcomed. We're a great bunch and supportive of one another, and it's a very unique place to work.
It is very unique, and I suppose that kind of brings us to a close really well, actually, just to say that we are national. It is very different working here than it is anywhere else. It's not your kind of classic acute trust, and even if you just want to come in and see what we do, like I said, as a student nurse, if you come to us for a placement, you'll rotate around the different areas if we have those different areas in your geographical location. There was a few questions early on about spoke days, spoke placements and such like. If you can either contact your local centre or you can go to your placement facilitators within your universities, and they can contact us. So I will put an email address into the chat box. So if you are interested, we will put you through to our national student nurse lead, for those that are looking for placements, etc., and you can contact her and see if there's anything that you can do. Yeah, so Torbay, I'm not quite sure what we've got down in Torbay Way, but again, we can see if there's an organ donation nurse. We definitely have lots of services, and we have placements with Exeter. So Exeter you'll be able to access placement through Exeter and Plymouth as well. So that's fantastic. And yes, you will. So you'll be sent out a feedback for today. So thank you everyone so much for spending some time with us today. All we wanted to do was showcase the work that our amazing nurses do and our amazing organisation, and say, yes, we are a bit different and we might not be your kind of classic employer, but do look out for us in the future. When you qualify, we're looking at different pathways of band 5s and TNAs and such like at the moment. So we're really opening up the door. And you know, just to invite you in and have a look at what we do, because like I said, we are a great place to work. Not that I'm biased at all. So no, I'm really pleased that you enjoyed that. So once you filled out the feedback, you will get a certificate to say that you've attended the 3-hour webinar today. And like, your feedback is really, really important to us so that we can make sure this is valuable for you. Cheryl has just put in an email address there. If you're wanting spoke days, I'm sure we'll overwhelm our national student lead now, but if you're wanting spoke days, or to find out about placements and who we're partnered with universities, do drop us a line through that email box, and we'll be in touch with you. Thank you so much, and it was really lovely to kind of virtually meet you all, and thanks for your time, and thanks to our speakers as well. Thank you. Bye-bye.